Good morning, everyone. Today's topic of seminar includes non-Wilms renal tumors of childhood. As we know, kidney is the primary site of 7% of childhood malignancy. As per US incidence, there are 7 cases per million children under 15 years of age. Most of these cases of renal tumor includes Wilms tumor. The another histology diagnosis varies with the age, with congenital mesoblasthic nephroma most common in the less than 3 months of age. Then in infants, most common tumor can be malignant rhabdoid tumor. Cystic clear cell sarcoma is rare after the age of 4 years. It is diagnosed mainly between the age of 2 to 4 years. And renal cell carcinoma becomes the most common tumor by the age of 15 years, preceding the Wilms tumor. As per the study conducted by Children's Oncology Group, ARIN 03B2, in which tumor biology and classification study was done for the renal tumors, the first 4,000 patients who were introduced in the study were classified as per the histology. It includes 75% of the favorable histology of Wilms tumor, 5% cases of anaplastic histology Wilms tumor, and rest of the tumor were the non-Wilms tumor, which include nearly 4% of the renal cell carcinoma, 3% of malignant rhabdoid tumor, 3% of clear cell sarcoma, and 2% each of congenital mesoblasthic nephroma and cystic nephroma. And 4% tumors were others, which included lymphoma, Ewing sarcoma, neuroblastoma, angiomyolipoma, and other benign tumors. Now we'll come to discuss each among them. First one includes the congenital mesoblasthic nephroma. It is the most common renal tumor under the age of 3 months and includes less than 5% of the all pediatric renal tumors. It has mostly the benign character. Malignant cases were also observed, but these are rare. It has male predominance and has excellent prognosis. Histological variants include 3 types, which includes classic, cellular, and mixed. In which 66% cases are of cellular variety, 25% cases are of classic variety, and rest were mixed, showing the features of both classic and cellular. Most common genetic aberrations which were noticed in the cellular histology included translocation between chromosome number 12 and 15, leading to fusion of ATV6 and NTRK fusion gene.
That is recording, but are we sharing the same screen which we are talking?
Yeah.
That is the screen.
Because it's not located, so which is more. Yeah.
I have not observed that part.
Histological variants of congenital mesoblasthic nephroma includes 3 types, which include classic, cellular, and mixed. In the gross appearance, tumor has a leiomyomatous appearance. On the cut surface, it will be having whitish appearance with a adipose tissue-like features. In the classic variants, it appears like a leiomyomatous pattern with interlacing spindle cells and will have low mitotic activity but absence of necrosis. It has an infiltrating growth pattern around the adjacent parenchyma and the perirenal fat, and it resembles infantile myofibromatosis. In the second type, that is the cellular one, it shows dense cellularity with high mitotic activity and the necrosis, but there will be less invasive growth patterns, and it resembles mainly with the infantile fibrosarcoma. Mixed pattern shows features of both, that is classic and cellular. All the stages of CMN and stage 1 and stage 2 tumors of cellular CMN are treated with the surgical section, that is mainly radical nephroureterectomy with lymph node sampling without the adjuvant chemotherapy. Overall survival, which was noted without adjuvant therapy, was 95%. It has potential to recur and metastasize, mainly which occurs in the patients with cellular histology and stage 3 diseases. The factors which are responsible for the metastasis includes the cellular histology and the stage of the disease, which is type stage 3, and age at diagnosis. That is, the patients with more than 3 months of age diagnosed with CME, there are high chances of recurrence and metastasis. The use of adjuvant chemotherapy in patients with cellular CMN with stage 3, the role is controversial. There is no role of radiotherapy in patients with CME. Recurrent CMN with ETV6 NTRK fusion gene can be treated with targeted pan-TRK inhibitors like lerotricitinib. The advantage or the features are under the process for the same. Now we come to the next cystic tumor of the kidney, which includes the cystic nephroma. There are mainly three tumors which are included in the cystic tumors of the kidney, which includes cystic nephroma, cystic partially differentiated nephroblastoma, and cystic Wilms tumor, which includes cystic nephroma is the most benign of them, and cystic Wilms tumor is the most malignant of them, and cystic partially differentiated nephroblastoma is of intermediate variety. Now we come to the cystic nephroma. It's a benign renal lesion and has a bimodal age distribution. In the children, it mostly occurs in the age group of less than 2 months with male to female ratio of 2:1. That is, it is commoner in males. However, in the adults, it is common in the females with a ratio of 8:1. It usually presents with an abdominal mass, which is found on the routine physical examination, or it can be found as an incidental finding on radiographic studies done for the other pathologies. It is mostly unilateral and rarely it is bilateral. On the gross appearance, cystic nephroma is well encapsulated tumor which is multilocular and has various size cysts with thin septations that compresses the normal kidney. On the microscopic finding, this tumor is differentiated from the other, mainly of the Wilms tumor, with the finding of only presence of the mature cells within the septa of the cyst wall, which should be free of any nodularity, and there should be no blastomal or embryonal component. Treatment mainly includes the nephrectomy. This is the MRI image of a patient which shows the classical cystic tumor, that is the main encapsulated tumor with a multiple cyst of variable size. Now we come to the next tumor, that is cystic partially differentiated nephroblastoma. It is again a benign, solitary and cystic lesion, occurs mainly in the first 2 years of life, can have presentations of abdominal distension with an abdominal tumor size extending up to the size of 18 centimeter in the diameter. It is well circumscribed and sharply demarcated from the normal kidney. It is characterized by the presence of the cyst with blastomal and other immature elements in the cyst wall. And skeletal muscle fibers are also common in these tumors. The treatment includes nephrectomy. There are chances of recurrence if there is incomplete resection. So during the surgery, we have to ensure that total resection has to be done. Another renal tumor which includes is the malignant rhabdoid tumor of the kidney. Initially, it is described in 1978 as rhabdomyosarcomatoid variant of the Wilms tumor. Haas used the term rhabdoid tumor in 1981 because there was absence of muscle differentiation. Malignant rhabdoid tumors got this name at the rhabdoid tumor because of the prominent acidophilic cytoplasm which is resembling the rhabdomyoblast. It can occur throughout the body in every tissue, including kidney, CNS. In the CNS, when rhabdoid tumor occurs, it is known as atypical teratoid or the rhabdoid tumor. Other locations where the rhabdoid tumor can occur include soft tissue, liver, or other sites. Rhabdoid tumor of the kidney accounts for 2% of all the renal tumors. It is most aggressive and lethal of all the pediatric renal tumors. Most commonly occurs in infants and toddlers, with 85% of cases occurring within first 2 years of life, and then there is sharp decline thereafter. Clinical features which are distinguished of rhabdoid tumor of the kidney from the Wilms tumor includes hypercalcemia, and there is diffuse lymphatic hematogenous spread seen in young infants. The prognostic factors which are predictive for a poor survival rate includes the age at diagnosis. That is, if an infant is diagnosed with rhabdoid tumor, it has a dismal prognosis, whereas older children can have slightly favorable outcomes. Mostly higher tumor stage will be associated with poor outcome, and if there is associated presence of a central nervous system, it is again an indication of poor survival. Rhabdoid tumor of the kidney mostly present at the advanced stage and they are resistant to the chemotherapy. They are associated with second primary tumors in the brain, including cerebellar medulloblastomas, pineoblastomas, neuroblastomas, and subependymal giant cell astrocytomas. Gross features include it's a solid tumor which is unencapsulated and have extensive hemorrhage and necrosis, and the tumor is highly invasive and metastatic at the time of presentation. In the microscopic feature, particular patterns shown by the cells include the whorl pattern, which includes there are sheets of cells which will be having nuclear pleomorphism and characteristic feature of open vesicular nuclei and prominent nucleoli and scattered hyaline eosinophilic cytoplasm inclusions, which gives appearance of an owl-like appearance. And these make a form of whorl pattern. Immunohistochemistry for rhabdoid tumor of the kidney includes polyphenotypic IHC staining, which includes that it is positive for a variety of markers, such as vimentin is diffusely positive in these tumors. Other markers which are found include the smooth muscle actin, neurofilament, and CG99. The most important marker which includes is the genetic alteration in the gene SMARCB1, which is also known as with the name of HSMN5, INI1, and BAF47. It is mainly present in all the tumors of the kidney except the rhabdoid tumor. Okay? If there is absent, these are absent from the nuclei of the rhabdoid tumor cells. This gene is ubiquitously expressed in proteins, and there is positive nuclear staining in the non-neoplastic tissue within the tumor, that is the vessels, lymphocytes, and the normal kidney. So it serves as an internal control for the staining. The childhood oncology group and the SIO group have reported poor outcomes for the children with the rhabdoid tumor of the kidney. The outcomes which are given in the National Wilms Tumor Study 5 includes that 5-year survival for stage 1 tumors is 50% with a 0% survival for a stage 5 disease. Its management is done with the multimodal therapy, which includes surgery, chemotherapy, and radiotherapy. However, the outcome is still poor. Initially, it was treated on the regimens for Wilms tumor, which included vincristine, dactynomycin, doxorubicin, with or without the use of cyclophosphamide. However, the overall survival, which was noted, was around 20%. Then, in the National Wilms Tumor Study, the regimen which was adopted included the RTK regimen that includes the chemotherapy drugs, carboplatin, etoposide, alternating with the cyclophosphamide. However, there was no improvement noted as compared to the previous studies. In the next study of the children oncology group, that is ARENA 0321, the regimen UH1 was noted, which was found to be beneficial for stage 1, stage 2 disease. But however, it did not demonstrate improved outcomes with stage 3, stage 4 disease. So for these diseases, the regimen which was used was initially revised UH1, followed by irinotecan and vincristine window therapy, and followed by a revised regimen UH2. However, overall survival outcome is still poor, and in the future efforts, novel biologically target therapeutic options are being investigated. The further class will be continued by Sona. Thank you.
Good morning, one and all. I will be discussing regarding renal cell carcinoma or hypernephromas. 6% of the malignant renal tumors in children and adolescents are encompassed by renal cell carcinomas, and less than 0.5 to 2% or 0.5 to 2% of these occur in patients who are less than 21 years of age. The mean age of presentation is 9 to 15 years, and there is no sex predilection in pediatric renal cell carcinomas. There are a multitude of histological subtypes which can be seen in pediatric RCCs, which translocation morphology being the most common type, followed by papillary RCCs. These primarily arise from proximal convoluted tubules, and these are the clear cell and the papillary subtypes, and other histological subtypes such as chromophobe RCCs, collecting duct carcinomas are derived from more distal components of the nephron. RCC should be suspected in any child who presents to us with a renal tumor who presents beyond 5 years of age. It can occur as a secondary malignancy in children who have undergone treatment for neuroblastomas, ALLs, or after exposure to chemotherapeutic drugs like cyclophosphamide as well. Exposure to asbestos factors such as smoking, obesity, and analgesic overuse have been known to be predisposing factors for adult RCCs. However, such an association has not been established for pediatric patients. Moving on to the clinical presentation. The classic triad or the Gravitz triad of flank pain with gross hematuria and palpable abdominal mass are rare. And it's good that they are rare because almost always when this triad is present, the disease is advanced, and thus it is known as the too late triad. Sometimes patients can present with an incidental presentation, or they can even present with spontaneous renal hemorrhage. Initially, these tumors were known as internist tumors because of the predominance of the systemic features rather than the local manifestations. And nowadays, we call them radiologist tumors because of the incidental detection. That is, more than 60% of the RCCs are incidentally detected. Moving on to the ultrasound and the radiological CT imaging presentation, these usually present as heterogeneous or hyperechoic lesions with both enhanced peripheral and internal vascularity in the ultrasonography. In the CT imaging, we can see that they present as heterogeneously enhancing masses, and they contain areas of both necrosis, and they can even contain coarse chunky calcifications. However, they can present as solid intrarenal masses, and there is no pathognomic finding on the imaging, which can help us differentiate it from the Wilms tumor classically. However, they are known to be more vascularized, and calcification is more commonly seen in RCCs compared to Wilms tumors. Sensitivity of the imaging to detect lymph nodal metastasis is low and is known to be around 57%. Hence, lymph node sampling is a must while we go in for the surgeries. Coming to the histopathological appearance, on gross appearance, they appear as gross yellow tumors versus the fleshy appearance, which is commonly seen in Wilms tumor. And the most common histological subtype, as stated before, are translocation type RCCs seen in almost 50% of these cases. These are similar to clear cell RCCs, with the cells being arranged in nested patterns with copious clear cytoplasm and papillary architecture, and some matters calcifications are seen. It is important that they lack immune reactivity for both for epithelial markers and for vermentin. It is important to distinguish between patients of adult RCC versus the patients which we will be encountering, that is patients of pediatric age group. As we can see, there is no sex predilection in pediatric RCC patients, and compared to adults, these patients tend to present more with signs and symptoms of the primary tumor, vis-a-vis adult RCCs in which the incidental diagnosis and metastatic disease presentation is common, and also paraneoplastic phenomena are pretty common. That is, these patients will present with fever, hypertension, hepatic dysfunction, polycythemia, etc. However, in our pediatric spectrum, patients tend to present with the primary tumor per se, or they can be incidentally diagnosed. Again, bilateral presentation is seen to be more common in pediatric RCCs versus adult RCCs. And as we stated below that before, that the translocational type of RCCs and the papillary RCC subtype is more common in the pediatric age group vis-a-vis the clear cell type or the non-papillary histology, which is often encountered in adult patients. Again, in imaging, tumor calcification is, it's not that adult RCCs will not have tumor calcification, but it is more common in pediatric patients. Again, in the IHC or the genetic factors, the translocation of chromosome X and the transcription factor TFE3 gene will be positive in pediatric patients. However, translocation and deletion of chromosome 3P is more common in adult patients who are encountering RCC. These can also be distinguished from Wilms tumor because, as we all know, that the most common tumor or renal tumor which we encounter is Wilms tumor, who usually present with painless abdominal lumps. Coming on to what to do and what outcome to expect in patients when we are dealing with patients of pediatric RCC. It's important to note that surgery is the mainstay of treatment for these patients, and radical nephrectomy with regional lymphodectomy is the modality of choice. Chemotherapy and radiotherapy resistance is noted in patients with pediatric RCC, and the role of immunotherapy is a new uncharted territory. Role of nephron-sparing surgery is also limited only to tumors with the lower stages, and the role is still not well established in patients with pediatric renal cell carcinomas. What would we expect in a patient who presents with RCCs? For patients with advanced metastatic diseases which are unresectable at the time of presentation, the management options are limited. However, in patients with pediatric renal cell carcinomas, the outcomes are supposedly known to be better compared to patients with adult RCCs. Patients with stage 1 to stage 3 are known to have about 100% 5-year survival rate if managed properly and in time. However, patients with stage 4 have less than 10-year 5-year survival rate. Moving on to the staging of RCC, till the 1990s, Robson's staging of RCC was a well-established system. He divided the tumor stage into stage 1, stage 2, stage 3, stage 4 based on the location or the involvement of the tumor with respect to the kidney. If the tumor was confined within the kidney with no perirenal fat involvement, it was considered to be stage 1. However, if it invaded the perinephric fat, however, it did not invade the Gerota's fascia, it was supposedly stage 2. Beyond this, if the tumor was involving either the inferior vena cava or any lesional lymph node, it was considered to be stage 3. And as we all know, that stage 4 would involve adjacent organ involvement other than adrenal glands and distant meds. So what was the problem with this classification? The problem was, one, that the extent of the venous involvement was not accounted for. That whether the tumor is involving the suprahepatic IVC, intrahepatic IVC, that was not taken into consideration. The tumor size was not incorporated into this classification system. And it included that the tumors with lymphatic mets and the tumors with venous involvement, both were categorized as stage 3. However, the prognosis for both of them can be varied, extremely different, because we can still manage patients with venous involvement compared to patients with lymphatic mets who have a poorer outcome. So we brought in the TNM staging in the year 2016, and this has been modified multiple times. According to the TNM staging, as we can see, the tumors which were confined to the kidney were classified as T1 and T2 based on their size. T1A was attributed to tumors less than 4 centimeters confined within the kidney. T1B was attributed to tumors more than 4 but less than 7 centimeters, again confined to the kidney. In T2, tumors which were though more than 7 centimeters but less than 10 centimeters were and confined to the kidney were included. And in T2B, tumors which were more than 10 centimeters but still confined within the kidney were included. That is, in T1 and T2, the tumor is still within the kidney. In T3, they have subclassified it into T3A, T3B, and T3C. In T3A, it is similar to the stage 3 of Robson's classification. That is, the tumor is extending to the renal vein or its segmental branches, or it can even invade into the PCS, or it can invade into the perirenal and the renal sinus tract, but it will not go beyond the gyratosphagia fascia. And T3B and T3C have accounted for the renal involvement, or the IVC involvement. That is, if it is grossly extending to the IVC below the diaphragm, it is counted as T3B. However, if it goes beyond the IVC above the diaphragm, or it involves the wall of the vena cava, it is labeled as T3C. And again, T4 is similar to Robson's 4, that is, it is invading beyond gyratosphagia fascia, which will include contiguous extension into the ipsilateral adrenal gland. And lymph nodal and NNM staging are similar to the routine staging of any other tumor. That is, involvement of regional Mets lymph nodes or Mets in the regional lymph nodes, and distant metastasis or not. Based on the TNM staging, we have classified RCCs into stage 1, 2, 3, and 4. So what were the adverse prognostic factors which would come to our mind when we encounter a patient with RCC? The tumor size is an important anatomic factor which we have to take into consideration while thinking of the prognosis of the patient. Again, the venous involvement, extension into the contiguous organs such as adrenals, the presence of lymph nodal metastasis, and of course the distant metastasis. These are the anatomic factors which are important. Then the clinical factors with which the patient is presenting to us, the systemic symptoms, presence of excessive weight loss, that is more than 10% of the body weight of the patient, presence of hypercalcemia, elevated LDH, ASR, ALP, CRP, all of these are adverse prognostic factors. Similarly, histologically, once we have seen the HP, presence of high-grade nuclear pleomorphism, sarcomatoid features, presence of necrosis, vascular invasion by the tumor, and of course, positive surgical margins are again considered to be negative or poor prognostic factors. For surgical management, radical nephrectomy is the treatment of choice. This is based on the principle that we have to go in and early ligate the renal artery and vein, followed by removal of the kidney, along with primary dissection external to the gyratosphagia fascia in order to avoid tumor swell, and excision of the ipsilateral adrenal gland, along with extended lymph node dissection. Excision of the adrenal gland is not a mandatory or a routinely done thing. If we feel that the adrenal is involved intraoperatively or based on the imaging, then we have to go for adrenal gland excision. However, it is not mandatory. Similarly, extended lymph node dissection, that is dissection of lymph nodes from the crus of diaphragm till the aortic bifurcation, have been described traditionally. However, nowadays this theory has been challenged, and it is believed that only in patients who have either enlarged lymph nodes on imaging or who have large tumor sizes, that is more than 10 centimeters, with high nuclear grade and sarcomatoid histology, presence of tumor necrosis on imaging, and again tumor thrombus involvement in the IVC. Only in those cases we should go for extended lymph node dissection. Moving to the steps of radical nephrectomy, most commonly it is done in the modified lateral decubitus position, and the subcostal flank incision is the most commonly used incision of choice. After we've entered the peritoneal cavity, we try to, for right-sided tumors, we'll go for incision along the white line of Toll from the pelvis, that is near the bifurcation of the iliac arteries, to the right upper quadrant, and we will try to expose the duodenum. After we are able to visualize the duodenum, we try to do cauterization or Cocker's maneuver so that we can lift up the duodenum and we can flip it to the opposite side, that is the left side. After we've done cauterization, we'll be able to identify the IVC, and we try to do the dissection anterior to the IVC so as to identify the renal vein. The renal vein will be the first structure which we can identify, and just behind the renal vein, we'll be able to identify the renal artery as well. It is important to know that traditionally it is described that the renal artery, though placed posteriorly, is the one which is to be ligated or clipped earlier, followed by renal vein ligation. This is done so that the kidney and the tumor both they decrease in size and engorgement, and it becomes easy to dissect the kidney at the hilum. Then, before clamping or before the ligation of the renal vein, it is important to examine it for any tumor thrombus. After we've done that, we can ligate and divide it. Sometimes it is due to the large size of the tumor itself, per se, we might not be able to find the hilum or the pedicle separately. So in these cases, we might consider doing whole clamp pedicle technique in order to control the hilar vessels. In this, we place 3 clamps. One is as distal as possible, or as proximal as possible to the IVC, followed by 2 clamps placed more distally, and we divide between the clamps labeled 2 and 3. And after that, we doubly ligate the remaining vascular pedicle and move on. Lymphadenectomy is an important part of the surgical management. It is mandatory to do lymph node sampling in all pediatric RCCs, as we discussed before, because imaging might not be suggestive of involvement of the lymph nodes. So it is important to do lymph node sampling. For right-sided renal cell carcinomas, we go for the hilar lymph node dissection, along with the aortocaval ones, along with the retrocaval ones, and also the ipsilateral common iliac lymph nodes. Similarly, for left-sided RCCs, we include hilar, para-aortic, and ipsilateral common iliac nodes. So just to summarize, RCCs will be most commonly seen in patients from 9 to 15 years of age. We should suspect RCC in any child more than 5 years of age who's presenting to us with a renal lump or a renal mass. Paraneoplastic syndromes or paraneoplastic features are less commonly encountered in pediatric RCCs versus adult RCCs, but still they account for 5 to 6%. And these tumors are more vascularized, and more calcification is present in these patients. Again, histopathologically, translocation pathology of chromosome X is more commonly seen, and transcription factor 3 might be positive in these patients in pediatric RCCs. Radical nephrectomy along with lymph node sampling is the standard treatment of choice. However, in patients who have generalized metastasis at the time of presentation, interferon 6, IL-2, and tyrosine kinase inhibitors such as rapamycin and sunitinib are still being studied upon. If managed properly, stage 1 to stage 3 can have good 5-year survival rates that can reach up to 100%. However, for stage 4 patients, around 10% survival rate is known. Moving on to another important renal tumor, that is clear cell sarcoma of kidney. It's a highly malignant tumor with usual proclivity of bony metastasis, and around 6 to 7% of these patients present to us with mets at the time of initial presentation. The second most common kidney tumor in childhood, accounting for 2 to 5% of the same, and a male predominance is noted in these patients. The age group is similar to that of Wilms, that is around 36 months of age, and they were initially considered to be an unfavorable variant of Wilms tumor, like a rhabdoid tumor of kidney. However, in 1970, they were divided into a distinct clinopathological entity itself. So how is the clear cell sarcoma different from a Wilms tumor? It has a more aggressive biological behavior. It has a tendency of late relapses and recurrences. Therefore, follow-up is extremely important in these patients. They have propensity for skeletal and brain metastasis. However, they have absence of any familial associations or syndromic associations, like in Vagar, which we see in Wilms. Similarly, there's absence of any associated nephroblastomas, like we have nephrogenic risks in Wilms tumors. Vascular extension into the renal IVC, renal vein in the IVC, though it's not that they would not be there, but they are rarer compared to Wilms tumors. And vascular thrombosis in clear cell sarcoma, if present, are usually non-adherent to the vessel wall, and they can be excised. These patients present similar to Wilms tumor, that is, they present with abdominal mass distension and sometimes with hematuria. Constitutional symptoms like fever, vomiting, bony pains can also be present. Metastases are most commonly to lymph nodes, followed by bone, lung, and liver. And around 30% of these patients will present with relapses more than 2 years after the diagnosis. Relapses were historically known or documented to be more commonly seen in bone, but now with the, chemotherapy, it has been seen that brain has become the new most common site of recurrence for these patients. Moving on to the imaging, in ultrasound, we will see inhomogeneous pattern of soft tissues echoes and well-defined echo-free areas corresponding to the tumor necrosis. When we move on to the CT imaging or the cross-sectional imaging, we can see that it's a usually unilateral, well-defined soft tissue component with necrotic areas, as we can see in this image, along with areas of calcification. In unlike Wilms tumors, if there are multiple patterns of histopathology which are coexisting, we should be considering clear cell sarcoma in these patients. Grossly, these patients, the tumors appear as large unicentric tumors with glistening surface. This is because of the mucinous material which is produced. Histopathologically on the HP, it can be diverse. That is, the pattern can be sclerosing, myxoid, epithelioid, cellular patterns. And this pathological heterogeneity makes clear cell sarcoma a diagnostic challenge for a pathologist. The classic pattern, which has been studied or is seen in more than 90% of the cases, involves nests of pale stained cells, which are separated by delicate but distinct network of vascular septate. This is known as the chicken wire appearance. And similarly, the nuclei are vesicular but poorly stained with chromatin, and inconspicuous nuclei are seen. We cannot identify the nuclei in the images very clearly, and this is known as the orphan Annie appearance. Moving on to the IHC markers. IHC markers which are specific for clear cell sarcoma include vimentin, cyclin D1, and nerve growth factors. However, these tumors are characteristically negative for WT1, and desmin, and cytokeratin. Another upcoming marker for diagnosis of CCSK is the strong nuclear positivity with BCL6 co-receptor antibody or the BCOR antibody, which is now being studied as a sensitive and specific marker for these tumors. Moving on to the management of clear cell sarcomas, as per the COG in their NWTS5 study, they advocated that all patients of clear cell sarcoma, irrespective of the staging, should undergo primary surgery, that is radical nephrectomy, if it is possible safely. This should be followed by post-operative chemotherapy, that is regimen I, and radiotherapy for 24 weeks. Regimen I, as you all know, includes vincristine, doxorubicin, cyclophosphamide, alternating it with cyclophosphamide and etoposide. And the 5-year survival rate, which was the effective survival rate, was 79% in these patients, and the overall survival was 89% in these patients. However, around 20% had relapses. Primary surgery, that is radical nephrectomy with lymph node sampling, should be done in resectable tumors. However, if that is not feasible, COG advocates that give them neoadjuvant chemotherapy for 6 weeks and then follow. Post-operative adjuvant chemotherapy for stages 1 to 3 include a regimen of etoposide, cyclophosphamide, vincristine, and doxorubicin. However, for patients with stage 4, carboplatin is added to the mix. Post-operative radiotherapy is administered for stages 2 to 4 as well. However, SIOP advocates administration of preoperative chemotherapy for stages 1 to 3, which includes dactinomycin and vincristine. However, we add doxorubicin to the mix when we encounter patients with stage 4. And this is done for 4 to 8 weeks. This is followed by surgery and then post-operative adjuvant chemotherapy for another 36 weeks. Again, radiotherapy has been allocated in post-operatively for patients of stage 2 and 3. And the 5-year survival rate, as per the SIOP protocol, was 78% effective survival rate and 86% of overall survival rate, with again a relapse rate of 15%. So just to summarize, clear cell sarcoma, the median age of presentation would be around 3 years, which is similar to Wilms tumor. These tumors usually present as locally advanced diseases. They are unresponsive to the conventional Wilms tumor chemotherapy, which we start in patients, and they have a tendency for skeletal and brain mets. Late relapses and recurrences are extremely common in these patients, and they should be watched for. They are rarely bilateral tumors, and vascular involvement is comparatively rarer vis-a-vis Wilms tumor. Histopathologically, multiple patterns can be seen in the same tumor, and when we see these patterns, we should immediately think that the patient might have clear cell sarcoma. The characteristic chicken wire appearance and the orphan Annie appearance in the nuclei can be seen, and in IHC, cyclin D1 positivity with WT1 negativity is characteristically noted. If the tumor is resectable, we go for radical nephrectomy with lymph node lymphadenectomy or the lymph node sampling, followed by chemotherapy and radiotherapy, apart from stage 1 patients. And if unresectable, we go for neoadjuvant chemotherapy for 6 weeks, followed by reevaluation. Moving on to the other smaller tumors of kidney, these are less commonly encountered tumors of kidney, the intrarenal neuroblastomas. These are rare, aggressive renal neoplasms which mimic clinically and on the radiological imaging Wilms tumors. These usually originate in the adrenal nests, which are located in the renal tissue, or they can originate from the intrarenal sympathetic ganglia. Usually, the patients present at a younger spectrum, that is 1 to 4 years of age, and the mass is usually not distinguishable from the Wilms tumor on radiological imaging. However, it can mostly cross midline. Presence of associated hypertension is extremely common in these patients. Nearly 2/3 to 100% of these patients will present with hypertension, compared to nearly 1/5 patients, 1/5 of the patients with Wilms tumors who actually present to us with hypertension. So presence of hypertension should raise the question of intrarenal neuroblastoma in our minds. Metastasis to bone marrow, and lymph nodes are commonly seen, and they can be seen in 80% of these cases. And intrarenal neuroblastoma should always be considered in a child presenting with renal mass who presents with hypertension with multifocal intrarenal calcification and evidence of vascular encasement on the imaging. As we can see in the imaging, we can see that there is vascular encasement, as we can see encasement of the renal artery in this particular section. Also, we can see calcification, that is speckle, multifocal and ring-like calcification, which can be seen up to in up to 2/3 of the cases, and also massive retroperitoneal lymphadenopathy, which can be seen. In order to clinch the diagnosis, we can use other modalities such as see the levels of urinary catecholamines which are increased, use MIBG scans, go in for bone marrow aspirations, and the management involves use of cisplatin, doxorubicin, and cyclophosphamide-based chemotherapy with radical nephrectomy with adrenalectomy in these patients. So to summarize, the patient will be a 1 to 4-year-old child who is presenting with the renal mass with characteristic presence of hypertension and presence of calcification in the imaging. We can confirm the same by urinary catecholamines, MIBG, and bone marrow as our adjuvants, and the management is similar to neuroblastomas. The next less commonly encountered or rare tumor of kidney is the angiomyolipoma of kidney. These are benign tumors which are rare and account for only 0.3% of the renal tumors. Usually, these present at with the middle age and are less commonly encountered in pediatric population. However, if there is association with tuberous sclerosis, they can occur in the early age, that is within the first decade of life, and they are often multifocal and bilateral. Sporadic cases can be associated with neurofibromatosis or autosomal dominant polycystic kidney of disease, and these tumors originate from the perivascular epithelioid cells. Again, patients present with flank pain or acute abdomen due to hemorrhage, and this presentation is also an indication for surgical treatment, because otherwise these tumors are usually patients are not symptomatic with these tumors. They will present to us, if they're presenting to us with pain or acute hemorrhage, then we should consider them for surgery as well. Presence of retroperitoneal hematoma, that is the Van der List syndrome, or the hemorrhagic shock due to the tumor rupture, are rare life-threatening presentations with which these patients can come to us. These tumors are thick-walled, have thick-walled vessels, smooth muscle cells, and mature adipose tissue. And the presence of adipose tissue is characteristic hallmark of these tumors. Malignant transformation, though, is extremely rare in these patients, and hence nephron-sparing surgery should be attempted whenever it is feasible or possible in these patients. In the imaging, you can see heteroechoic renal masses with non-shadowing of the echogenic areas, and these are representative of the fatty elements of the tumor. And along with that, marked internal vascularity in these tumors. Again, in the cross-sectional imaging, the images of a heterogeneously enhancing renal mass with multiple hypodense areas, as demarcated by the arrow, which are areas of fat attenuation. Histopathologically, there are two main variants, that is classical and the epithelioid variant, and both of them are HMB45 positive in the IHC marking. Coming to the management, if the tumor is less than 4 centimeters, usually conservative approach is taken and annual USG surveillance is done. However, if the patient is presenting to us with tumors which are larger than 4 centimeters, or the patient is symptomatic, or and the tumor is prone to rupture, or we are suspecting that there is malignant transformation, or we know that the patient will not be able to come to us for regular follow-up, these are the places where we consider surgical resection for these patients. Nephron-sparing surgery is to be considered if either tuberous sclerosis is present with bilateral renal involvement, or in patients who have low nephrometric scoring. By low nephrometric scoring, we mean that the tumor is primarily exophytic, there is polar distribution of the tumor, and there is at least 7 mm or more distance between the tumor and the renal sinus or the PCS. Other modalities which have been seen to be effective or are being tried out in the management of these patients include selective arterial embolization with the gelatin microspheres and absolute alcohol and radiofrequency ablations. These are novel treatment options and have shown 60 to 90% success rates in these patients. However, bulky unresectable tumors, especially in those patients who have limited renal reserve, baseline renal reserve, mTOR inhibitors like sirolimus, rapamycin, and everolimus have been explored, and 30% response rate has been seen in these patients. To conclude, in AML, the age presentation can be variable. These patients can either have a sporadic presentation or can have a genetic predisposition with symptoms with syndromes like tuberous sclerosis. Patients usually present with a tender renal lump after a trivial trauma and flank pain and hematuria. Fat density in the lesion is the characteristic feature which has been seen. IHCH is HMB positive, and these tumors can be observed if the tumor size is less than 4 centimeters, and we can go for a surgical management if it is more than 4 centimeters or symptomatic. Moving on to renal lymphomas. The renal involvement in lymphoma is usually due to the systemic spread of non-Hodgkin lymphomas, which present with multiple or solitary metastatic nodules. And primary renal lymphoma per se is extremely rare. If they are present, they arise from mucosa associated with the lymphoid tissue. Hence, a specific diagnostic criteria for primary renal lymphoma should emphasize that there is absence of any other nodal or extranodal involvement. And these patients usually present with renal enlargement, which is bilateral in 1/5 of the cases, along with renal failure and hypertension. Multiple bilateral renal masses on imaging are often encountered, and it does not have any characteristic imaging finding, apart from retroperitoneal lymphadenopathy with involvement of liver and spleen. So based on imaging, it is very difficult to clearly identify whether it is a primary renal cell lymphoma. Renal failure in lymphoma can be either due to vascular or ureteric obstruction by the renal mass per se, or it can also be due to the enlarged retroperitoneal lymph nodes, or it could be due to the associated glomerulopathy. Renal failure is usually often aggravated by our induction chemotherapy, which leads to rapid breakdown of the tumor cells, leading to the tumor lysis syndrome, which can be managed conservatively. Management of the renal lymphoma is usually medical, involving use of vincristine, prednisolone, cyclophosphamide, L-asparaginase, and cytosine arabinoside.